Welcome to session 2. My name is Tricia Meyer, and I will be your moderator for this session. I'm going to keep my introductions brief. Well, nope, I want to get my introductions. Yeah. Yeah. There we go. Sorry. We're going to keep our introductions brief. This way we can add about 32 more seconds to each of the speakers' time. Again, we'll start with Dr. Joyce Wahr. Dr. Joyce Wahr is Professor Emeritus from the Department of Anesthesiology at the University of Minnesota, a well-known medication safety expert and author. We'll next go to Dr. Rick Botney. He was previously at Oregon Science and Health University, and he currently is the ASA representative on the USP for labeling and the APSF representative on the ASTM. We'll next go to Angela Lindsey, Vice President of Marketing at Fresenius Kabi. Then we'll go to Michael Greenberg, who's the Vice President of Medical Affairs at Eagle. And then we'll end with Erin Fox, the Associate Chief Pharmacy Office at the University of Utah Health. Dr. Wahr. There you go.
It's like, I will never do it.
That's good. Here we go.
Perfect. All right. Thank you, Tricia. And as you can see, my topic is immense, and I have 12 minutes. So I'm not going to spend time on financial conflicts, but I am going to spend quite a bit of time talking about Daniel Kahneman's work in experimental psychology. He died earlier this year, but a giant in the field. Many of you may know him from his book, Thinking Fast and Slow. And if there is one thing you take away from my talk today, buy the book. Read it slowly. It will completely change your idea about how we achieve patient safety and what interventions are pretty much useless. So Daniel Kahneman won the Nobel Prize in economics, of all things, for the work that he did with Amos Tversky, an academic colleague, and they just sat around asking each other questions. And one of the biggest questions they asked was around this area of bounded rationality. And the question was, why do people make stupid decisions? For example, a ball and a bat together cost $1.10. The bat costs $1 more than the ball. How much does the ball cost? And in all of your minds, the first thing that comes to mind is 10 cents. And it's wrong. And so this is the sort of thing, it's 5 cents. This is the sort of thing that Daniel and Amos worked on for a period of about 10 years. And one of their first papers was Judgment Under Uncertainty. So when things are not really obvious, we tend to make erroneous decisions. And that's because we rely on some heuristics, some shortcuts to reduce the complexity of what we're being asked to do. And these heuristics allow our brains to think very, very fast, but it also leads to some severe and systematic errors. So I think we know Thinking Fast and Slow, Drs. Kahneman and Tversky did not come up with that concept, but they really explored how the two interact. Fast thinking is what we do. We drive to work. We put a patient to sleep. We compound medications. We do it effortlessly. It's a routine we're in, and we love being in system one thinking. Our system one is continually running in the background, assessing our situation, taking all the information in, and fitting those perceptions into a mental model that makes sense. System two is slow, it's conscious, it is the rational mind, but it requires a lot of effort. For example, you cannot do this with system one, but 17 times 24. That's going to require some effort. You'll get there, but it will require effort. But we can perhaps use system two to supervise system one, but it cannot change it. How many of you know this diagram? Yeah. So system two tells us the correct answer is the horizontal lines are of equal length. System one cannot see it. Oh, yeah, sure. We see it. No, we don't. Our system one overrides the actual information that's coming in and puts it into something that's more coherent. So just very, very briefly, some of the shortcuts we take, the availability heuristic. What is the mental model like this, like my perceptions, that I use the most often? Or it's the one I saw most recently, or maybe a powerful emotion is associated with that mental model. But there's also a confirmation bias. System one loves coherence. And it will, if the perceptions don't quite fit into that mental model, it will change the perceptions. And it distorts, it autocorrects. If you're shown a schematic of a bedroom, two beds, a bedside table, a little alarm clock on the table, and I flash it up, everybody recognizes it's a bedroom. When I ask you, what's the time on the clock? People will give you an answer, usually 6 o'clock, 7 o'clock, whatever time their alarm goes off. There are no hands on the clock. System one fills in the gaps, often with wrong information. All of us know about this one. And I want to ask our pharmacists and everybody here, stop asking us to read the label. System one will correct what you are reading if it doesn't fit the mental model. You're preparing for a spinal anesthetic, you pick up the vial, and it says tranexamic acid. System one says, no, that doesn't fit my mental model, it must say bupivacaine. And so when things look alike, it's easier for system one to do that override. And these are the examples from the literature of bupivacaine and tranexamic acid. The vials actually are a little bit easier than the ampules, but you cannot fight system one. And part of the reason you can't, using system two requires effort. There are limited reserves of effort, and there's a ton of competition for those reserves. I asked you before, what's 17 times 24? Now, I'll put you on that little trail in Prospect Park out in Waltham, and we're walking up that last bit, coming up to the overlook. You're looking where your feet are because there's steps and it's stony and it's uneven. Now I say, tell me what's 17 times 24. You will stop walking. You cannot do two effortful things at the same time. And there aren't separate reserves for emotion versus physical. That's all one. That's why you stop walking. So if I have spent the morning resisting the urge to snap back at my snippy surgeon, I may not have the effort reserve to carefully read the label. Effort does not work. And we've said this again and again and again, try harder is the weakest thing we can tell somebody, even re-educating them. Every anesthesiologist knows you do not put tranexamic acid into the CSF. Education does not help. We need forcing functions. We need pin indexing. We need our small bore, unique small bore connectors. We need tranexamic acid to come in a mini bag, not in a syringe, not in an ampule. And we need our bupivacaine to come in a syringe that's a Nerfit, right? The one that can only attach to the Nerfit spinal needle. We need those forcing functions. Many of you in this group figured out with the first Stoelting conference what we needed to do. We know what we need to do, but we are not doing it. mHealth Fairview does not have barcode readers for medication administration. And I that last year fought so hard to get pre-filled, pre-mixed. We just say, we don't have the time, we don't have the money for it. Yes, we do. If we can buy robots, we can get $15,000 barcode readers. So call to action, and clearly that's what tomorrow's going to be about. But if APSF, instead of just telling us what to do, can we get a sophisticated marketing group together and put together the arguments, the rationale that we can take to our finance group to justify buying our barcode administration, our devices. And ISMP, thank you so much, Rita, for making barcode administration in the operating room a national goal, I think 2 years ago, but now we need some teeth. And perhaps more than anything else, every one of us here, every leader in patient safety needs to recognize that system one is the elephant. System two, effort, is a tiny little rider on the elephant. Just exhorting the elephant to go in the right direction is not going to work. We need better actions. We know what those actions are. Let's just do it. Thank you.
Yeah. Let's see.
Right side.
Yeah.
Go back.
Oh, yeah. Let's see. Right here.
Nope. Nope.
That's not it. Oh, Rick, I'm sorry. Yeah. Let me close that. Yeah. Okay. Try again.
You've got help. There you go. Got it.
Thank you.
Perfect.
Let me get this.
Good morning. I'm Rick Botney, and this is Medication Labeling 101. How do I do this? Forward. Good. So I occupy space on a number of different committees, but I have no financial disclosures. The top 3 committees are most relevant to what I'm doing here today. And so I'd like to set the stage by briefly reviewing some history related to medication errors and medication labeling, and then look at why we label medications, consider how standards differ from guidelines and statements. And then after that, I can discuss in more detail the ASA statement on labeling, the role of the United States Pharmacopoeia, and the standards that are published by ASTM. So John Snow discussed the death of Hannah Greener while she was under chloroform anesthesia. And this was likely the first report of a medication error in anesthesiology. He attributed her death to an overdose of chloroform that had been administered in an uncontrolled fashion. 20 years later, there was a medication-related death that was brought before the courts in England. And during the inquest, the doctor explained that the appearances of bismuth, the intended medication, and strychnine are similar. And that wherein the judge outlined two possibilities. One, that the poison had been administered by mistake, or two, that there had been gross negligence because the doctor's drugs and poisons might have been kept in such a way that he could not tell which he was using. I think this is a medication swap and probably occurred because the medications were not labeled. The first contemporary mention of medication errors was in 1953 in the nursing literature. Medication errors at that time were considered to be a nursing problem. And despite steps taken to reduce their likelihood, the errors continued to occur. The following year, Beecher and Todd reported on the death rate attributable to anesthesia and whether deaths were due to the agents themselves or to the techniques used, or whether errors such as the choice of agent or how it was administered played a role. One important finding they had was that muscle relaxants were associated with a high death rate. However, when they looked, the incidence of any clearly recognized gross misuse of these agents was so low that they stated it could hardly be called an important factor. In contrast, 30 years later, in their critical incident analysis of errors in anesthesia, Jeff Cooper and his colleagues found that drug administration errors and syringe swaps were the most common critical incidents in anesthesia in the operating room. In the 1990s, there were several things taking place. The Harvard Adverse Drug Event Study was conducted, and at the study's conclusion, a summary of the study was written of the previous 10 years experience, but a leading anesthesiology journal declined to publish it. And it suggested that medication safety in anesthesia was not a topic of significant interest at that time. However, soon thereafter, medication errors began to be recognized as a significant issue. They were discussion of them was being included in ASA programs, and publications on the subject were becoming more frequent. At the same time, the Australian Incident Monitoring Study examined 2,000 incident reports, and Curry and colleagues reported on 144 incidents that involved a wrong drug administration, and they found that 63% of syringe errors occurred despite correct syringe labeling. And this is where I want to thank Joyce Wahr for her comments about cognitive errors, because for various reasons, including no doubt those cognitive errors, correct labels were being read incorrectly. The authors concluded that labeling is only one of a range of strategies necessary to prevent syringe swap errors. And the 1990s also included ASTM's publication of the first international labeling standard. We'll see more on that shortly. In 2001, Webster and Meyer quantified the drug administration error rate as 1 per 133 anesthetics. And they also reported that most substitution errors involve drugs from a different class, suggesting that the use of color-coded labels would have considerable potential for reducing interclass errors. In 2004, the first statement on the labeling of pharmaceuticals for use in anesthesiology was published by the ASA. And more recently, Angie and her colleagues found that medication errors and adverse drug events occurred in 5% of all medication administrations in anesthesia, and that labeling was the most common type of error. So, why do we label medications? It serves several purposes. Its general role is to reduce the occurrence of medication errors. Although we know errors can still occur even when labeling is correct, it does not change the fact that labels, in my opinion, are a necessary and important part of the error reduction process. Labels enable the accurate identification of medications to make sure that the correct drug is being given. In addition, having the concentration displayed on the label can make or may make dosing errors less likely. Labels may also have additional information such as the patient's name and the route of administration, and that the medication is not beyond its expiration date. Standards, guidelines, and statements serve different purposes. Standards provide the expectation that a measurement or the production of an item will not vary and can therefore be trusted. That is, that things are done in a uniform way so that outcomes do not change and are reliable. In addition, standards are typically viewed as requirements and that they are enforceable. So now we'll get into the heart of the talk. The original ASA statement was approved and published in 2004. The gist of the statement was that the main consideration in label design was to reduce medication errors and promote safer patient care. The statement also showed support for the use of medication labels that were consistent with the ASTM D4774 standard. The most recent statement was approved and published in 2020. It had been significantly revised, mostly by myself, and has a fair bit of additional content. But the basic message of this statement is unchanged: to promote safe patient care through a reduction of medication errors. Also, by this time, the ISO had published an international standard for label design, so the ASA statement now supports the use of labels consistent with both ASTM and ISO standards, plus recommendations from the FDA and ISMP. The original United States Pharmacopoeia, shown here, the cover of which is shown here, was published a little over 200 years ago. There are a number of statements in the preface of the original publication, which are also shown here, that describe USP's role. The two underlined statements relate most to the topic of labeling. First, labeling helps to prevent uncertainty regarding the medication named on the label by ensuring that drugs have a definite name. Second, ensuring that medication names are not similar helps to avoid mistakes in medication identification and selection. In order to achieve these objectives, USP has created a robust naming process that is the responsibility of its nomenclature and labeling expert committee. USP standards are found in the US Pharmacopoeia as well as the National Formulary. These official compendia are recognized in the Food, Drug, and Cosmetic Act, and while compliance with the standards are mandatory, USP has no role in enforcing these standards. That falls to the FDA and other government authorities. The most relevant chapter for labeling is General Chapter 7. It specifies the label content for injectable products and describes a format for most of the items that we find on labels. It applies to official articles, which are medications for which they have written a monograph and to which an official name has been given. The primary expression of strength is almost always given as the total amount of drug per total volume, despite what many of us who are anesthesiologists believe is not the best way to do it. Exceptions do exist for circumstances where the primary expression of strength has not been effective in preventing errors. One example is insulin, and another example is the use of ratio expressions for single entity medications such as epinephrine. Because ratio expressions have been the source of frequent errors, they are no longer permitted for these single entity medications. Instead, the strength is now given as the amount of drug per volume, for example, 1 milligram per ml. Some other requirements in General Chapter 7 include labeling for potassium and neuromuscular blockers in recognition of their potential for deadly errors, for how expiration dates are expressed, for compounded preparations, the use of leading and terminal zeros, for electrolyte concentrations, and that certain abbreviations shall not be used. ASTM develops and publishes voluntary consensus standards with the help of over 30,000 technical experts and professionals like myself. Under certain circumstances, the standards can become mandatory. The 4 standards shown here are the ones that are important to our work. D4774 provides specifications for user-applied syringe labels and is possibly the most relevant. Additional standards specify the identification and configuration of pre-filled syringes, labeling for small volume parenteral drug containers, and methods to enhance the identification of drug names on labels. All of these were withdrawn by ASTM in 2022. And that means that they are no longer available for reference by organizations such as pharmaceutical manufacturers or label producers. To remedy this, APSF became a member of ASTM, and I was asked to represent APSF in order to get these standards reinstated and, where necessary, revised. The first one I worked on is D4774, which was first published in 1994. At that time, the only international labeling standard. It specifies color coding and other aspects of label design, including label size, content, and font characteristics, and how drug concentrations are represented. It also served as the basis for several national standards at that time, including in Australia, Canada, and the UK. When I reviewed 4774, I observed that it had a number of errors of various types, and its content needed to be aligned with contemporary practice. So I made the necessary revisions and submitted it for reinstatement. Hopefully, that will be accomplished in the next few months. Since ISO also publishes an international standard on user-applied syringe labels, why is reinstatement of D4774 necessary? Well, there are a number of differences between the 2 standards, which are shown in this table, or these tables, and I believe that 4774 is still relevant and necessary. For example, it is used in the United States market, while ISO is intended more for the international market. One way in which this is reflected is in the differing terminology used for certain drug names. For example, succinylcholine here and succinylmethonium in many other parts of the world. In addition, D4774 identifies 9 different drug classes and provides color coding for each of them, while ISO only identifies 8 classes. Local anesthetic concentrations, this is my slide, can be indicated as either percentages or in milligrams per mil, but ISO has no such specification. And the revised version describes tall man lettering in much more detail than ISO does. If I had to boil down my message, it would be these 3 items. Labels are important for reducing medication errors and improving safety. That label design matters in that endeavor, and that standards provide important guidance for label design. Thank you.
How do I X out of this, Arnie?
All right. Hello, everyone. Thank you. I'm Angie Lindsey, and I am very happy to be here with you today. First of all, I want to say that although I work for Fresenius Kabi, I'm not making any claims about the safety or efficacy of any of our products today, but I am excited to talk to you about labeling and the manufacturer's perspective. First of all, there are many opinions, both for and against using color on medication labels. And what we're going to discuss today are some of the considerations for these choices and what manufacturers are looking at when we make these choices. And also why lookalike errors continue to persist. So let's explore together what we can do. So here's a basic picture of a vial, and you've all seen this many times, but I just want to go over the places where manufacturers can interject color thoughtfully. The cap, the seal, and the label. The cap is meant to be a cover for the stopper. So from a manufacturer perspective, anything on the vial that is within the fluid path requires extractable leachable studies in order to make changes. And those studies are submitted to the FDA prior to our file being approved for the drug. The good news is the cap is covering the stopper. So the stopper is what is subject to these extractable leachable studies, which take time and resources. But if we were to make a change to the cap, and let's just say make a color change, choose a different color, that is considered an annual reportable to our FDA file. So we're just notifying the FDA that we are making that change. So it's fairly simple. The label, if we make changes to the label, I think Savan covered that earlier today, that is somewhere in the middle. That is not as extensive as extractable leachable studies, but it does require FDA approval. So we would submit that to the FDA for their approval of any label changes, which would include changing color to the label. All right. So today, label, cap, colors for the generic injectable drugs specifically are hugely variable, and they provide no consistency, really, for you as clinicians. Generic manufacturers either use the reference list drug and follow what the branded drug had for colors, or generic manufacturers can also select whatever color they want in their file. And as long as the FDA is approving that, there are no standards or guidance on color for the most part. We'll talk about that. So what I'd like for us to think about in this presentation is, could standardizing some color add another layer of safety to our system? So let's find out. So you've seen a lot of these pictures. This is from the APSF gallery of lookalikes. The first picture on the left is lidocaine and bupivacaine. They look very similar. The author that submitted this picture said that they attribute the color of a red cap to epinephrine being added to the vial. And in both of these cases, that is not true. So this attribute is not the case. The middle picture are 4 vials with very similar cap colors. The labels look a little bit different, but obviously glycopyrrolate, ondansetron, concentrate, phenylephrine, and metoclopramide are commonly stored in your anesthesia trays. And if they are stored with the cap up, this is very problematic, and which is why ISMP recommends storing these vials with the label up. The right picture, a lot of the same medications plus more. You also have concentrate dexmedetomidine. So if any of these products are mixed up, because they do look very similar, and a lot of these labels in the blue picture look very similar. that would be problematic. And I want to draw your attention to glycopyrrolate. So it's the first vial in the middle picture. It is the third vial in the picture on the right. So if you had to guess how many manufacturers, generic manufacturers or generic labels are out there for a glycopyrrolate vial, does anybody want to throw out a number? How many companies like Fresenius Kabi are making glycopyrrolate? Anyone?
30, 20.
Very close, 18. There are 18 companies like Fresenius Kabi that are making glycopyrrolate vials today, and that's manufactured vials. Now, 2017, I looked this up. There were only 4 manufacturers making glycopyrrolate vials. When I started with Fresenius Kabi 12 and a half years ago, we had 60 generic manufacturer competitors within our addressable market. Today, we have 123. So you think about all of those companies coming into the market, bringing vials, that's where this variability is coming. We do not have specific standards that we're following, when we're selecting colors for our products. Just earlier this year, another manufacturer was approved for a line of bupivacaine vials. They picked a different color for every strength and concentration, including Barbie pink is one of the cap colors. So this variation is continuing as more manufacturers come to the market. Situations that prompt change exacerbate risk. So when you think about all of the situations that may result in a change in which manufacturer vial your hospital or your institution is using, drug shortages are a big one. There's a lot of switches that occur with drug shortages, and also contract changes. They happen a lot where your hospital may be changing contract, because when you have all of these manufacturers that are coming to the market, 18 glycopyrrolate vial manufacturers, guess what? They all want on your contracts. So that's what's causing a lot of these changes. So when you think about, and actually I'm going to go back, when you think about that, how should we communicate changes to you, the end user? How should your pharmacy be communicating to that? So if your hospital is bringing in a different manufacturer of a product that looks significantly different, how should they alert you to that? That's a question to think about. So here's one more example, ISMP medication safety alert. So in 2022, there was an article, Scan Before You Flush. So a heparin flush syringe and a 10% calcium chloride syringe, both with bright yellow labels, they both look very similar, right? So this was published. So the manufacturer of the calcium chloride syringe said, okay, I'm going to change the color of the label so it's differentiated, and went with the dark brown. Well, guess what? In 2024, another article is published, another safety alert, that a healthcare provider during a pediatric code was delayed in finding that syringe because they were looking for the yellow syringe that they've been using for years and years. So again, that association resulted in a delayed treatment. So as we think about the guidance that manufacturers are following for labels, Savan did a wonderful job covering this earlier today. So, but we think about this, and generally, the FDA generally recommends avoiding color coding in most instances, which is why you see so much variability in labels today. But we do implement tall man lettering in our labels. We try to keep the label decluttered. So there is an opportunity, I think, moving forward. We are, as manufacturers, starting to put 2D barcodes on labels, which the 2D barcode offers more information for you as a clinician and for pharmacy. It offers the lot number and expiry within that scan. So a linear barcode is just giving you the NDC and the drug information. So if right now we're adding the 2D barcode to the label, so we have a linear barcode, a 2D barcode, and in some cases, even an RFID. So maybe someday we can eliminate that big linear barcode and just use the 2D again, to declutter the label so that your eyes will go directly to the name of the drug. Regulatory guidance on caps, very simple. Black for potassium chloride. And then we've talked already about neuromuscular blockers today, but cautionary statements are on the cap of neuromuscular blockers because it's there to prevent an imminent life-threatening situation. So what you'll see, generic manufacturers of neuromuscular blockers have paralyzing agent on the cap. But otherwise, there are no guidelines that we're following for cap colors and cap selection. So we believe that manufacturers should be considering how these drugs are being stored and how they are being dispensed, how they are being used as we're making those decisions for color and how to bring color into the label. So because of this, Fresenius Kabi did a project internally. And I have some of the members of that team that conducted the project are here today. But we did an ASTM color project and using the standards that Rick talked about previously. But we assessed the use of ASTM color specifications for all of our drugs that fall within the drug class of the ASTM colors for anesthesia. And we also created a portal where we could easily see the labels and the cap colors of all of our products. Now we have over 650 SKUs in total, but we're starting with our anesthesia products. And then we also collected insights from external and internal subject matter experts, and it's been a really good process. So what we found at Fresenius Kabi, so out of all of our drugs that we supply, we're a generic injectable company. 229 SKUs were eligible within the drug classes identified by this ASTM project. And only 13% were compliant with the ASTM colors today, which makes sense if you think about it, because for the last over a decade that Fresenius Kabi has been bringing these drugs to the market, we have not been thinking about the color and making any choices based on ASTM guidelines. So now we're starting to think about this. But 13% were compliant with the cap color and 14% had some of the color of ASTM in the label. So again, this was very interesting information for us to look at. So are there certain classes of drugs that we should be intentional about making these decisions, and what should we do about it? So here's just some examples. So we could put color around the secondary information, color around the primary information. We could be interjecting color on the cap. And here are some of the products that maybe we should be looking at, like narcotics, vasopressors, local anesthetics, or muscle relaxers. So I will conclude with the insights and recommendations. So one thing that we realized in doing this project, that Fresenius Kabi could not do this alone. I mentioned there's 123 other companies that are within our addressable market of generic injectable drugs. So if color were to be meaningful for you as clinicians, we would all need to do something together. But what we can focus on is implementing auto-identification technologies where possible, such as RFID, 2D data matrix, computer vision. We can dispense ready-to-administer drugs and make more of those for you, make the syringes that you need for your practice. We can analyze those high-risk situations like the tranexamic acid that has already been talked about. Fresenius Kabi made a decision this year to discontinue our tranexamic acid vial. There's 13 other manufacturers in the market that make it. We'll let them make the vial. We're going to focus on a premix bag. And then prioritize drug classes where errors could be lethal or have more severe outcomes. So a quick poll, and this is my last slide. All right, would adopting ASTM color standards for vials and prefilled syringes be helpful for you. And this is for all of us in manufacturing.
Are you waiting for the result? There we go.
Mostly yes, it
That
looked
was
like.
mostly-
Yes.
Right.
Thank you. Good morning, everyone. Mike Greenberg with Eagle Pharmaceuticals, and I'd like to talk to you about industry's response to mitigating potential medication errors in simulation training. So simulation training enhances emergency preparedness. Simulation training originated in the aviation industry, and although it's used throughout healthcare today in many different specialties and many different facets, anesthesia pioneered the use of simulation in the healthcare setting. The medical literature supports the fact that simulation-trained HCPs recognize emergency conditions better and more rapidly. They also manage these medical emergencies better, and simulation training is also an opportunity to identify areas for improvement. Malignant hyperthermia is a pharmacogenetic disease. In individuals who have the mutation or malignant hyperthermia susceptibility trait and are exposed to a triggering agent, which is certain anesthetic gases or the paralyzing agent succinylcholine, they may trigger with a malignant hyperthermia crisis. And malignant hyperthermia crisis is a hyperthermic, hypermetabolic crisis. It's rare. MH is not a mandatory reporting. However, we believe there are between 600 and 800 cases of MH that occur in the US every year. MH is unpredictable because everyone who manifests or harbors an MH susceptibility mutation does not necessarily trigger with an MH event on every exposure to a triggering agent. So it's rare and it's unpredictable. However, the incidence of the MH susceptibility mutation is between 1 in 2,000 and 1 in 3,000. So the risk of MH is far greater than the incidence of 600 to 800 cases a year would imply. Outcomes in MH are directly related to the time to recognizing and treating MH, and the key steps involved in treating MH include, among other things, removing exposure to the triggering agent and administering the antidote to the crisis, which is intravenous dantrolene. Routine training has been demonstrated to improve outcomes in patients who suffer from an MH event, and it likewise improves MH preparedness. In fact, routine training is mandated by multiple accrediting organizations within the healthcare space. Eagle manufactures a unique and proprietary concentrated nanosuspension formulation of dantrolene sodium. It's called Ryanodex. And Eagle also makes Ryanodex drill vials available to hospitals and health systems to support education, malignant hyperthermia, simulation, and training. Eagle has provided these drill vials to licensed HCPs and facilities for actually almost 8 years at this point. We also make them available through a partnership with the Malignant Hyperthermia Association of the US. And to date, we've disseminated almost 20,000 drill vials, which have been used for education and training throughout the country. So on the left, you'll see what the live or commercial product looks like for Ryanodex. And in the middle image, you'll see the Ryanodex drill vial. So this is how it was conceived at the inception of the program. And you'll note several differences between the live product and the Ryanodex drill vial. Specifically, there is no NDC number on the drill vial. There's no expiration date on the drill vial. Likewise, there is no barcode on the drill vial. Demo has been added in capital letters after the lot number, and there is auxiliary labeling indicating that it is for training purposes only and not for human use. And lastly, there is an auxiliary overseal tape over the drill vial. So these were the original safety measures to reduce the risk of a drill vial inadvertently being administered to a patient during a malignant hyperthermia crisis. In June of 2023, ISMP informed Eagle of an intercepted or near miss medication error. There was a hospital which stocks Ryanodex for the treatment of MH. They had requested drill vials from Eagle, which were provided, and that drill vial was then shelved in an area where live product is contained, most likely in a dispensing cabinet. Now, the storage error was identified before the product was used for patient care, so this wasn't actually a medication error, but it was a near miss medication error. And in addition to notifying Eagle, FDA was informed of this near miss error as well. So how did Eagle respond to this? Well, first and foremost, we needed to discuss this, the potential changes that were needed to mitigate this identified risk with leadership. As I'll demonstrate in the next couple of slides, maintaining this drill vial program and supporting MH education and simulation requires a significant commitment in terms of both manpower and funding. I'm happy to report that leadership was in favor of continuing to support education and training in the MH space. So once we agreed that we would proceed with updating the drill vials and the labeling to mitigate this risk, we conducted a root cause analysis as well as a targeted or modified failure modes and effects analysis to develop an action plan for addressing this issue. The action plan was two-pronged. There were some process improvements that were identified, such as providing alternate shipping location for these drill vials, so not going to the main pharmacy area. This was something that was not necessarily done previously. Another process improvement was again suggesting, we can't mandate this, but suggesting that the drill vials be stored in non-patient care areas. At some facilities, this is quite practical where they have a separate classroom setting and they're able to get all the different shifts of healthcare providers who require training into that classroom setting for the training. Other times it's a little bit less practical, and the only time you're really going to have the groups together may be at shift change at the OR desk, and so it's a little bit less feasible to store this training product in a non-patient care area. And auxiliary labeling within whatever area the drill vials were stored was another potential improvement that was identified. We also identified opportunities to update our drill vial product to reduce the risk of potential medication errors, and those include improving the visibility of the auxiliary labeling and demo, and improving the visibility by changing the color of the font, and likewise moving that auxiliary labeling to above the product name. In an emergency setting, it's not uncommon to reach into the drawer or reach into the Pyxis, look at the product that you're grabbing. As soon as you see the name, you stop because you think you've identified the right product in an effort to speed patient care. So this way you'll identify the auxiliary labeling before coming across the product name. There were also certain other improvements we were able to make, which I will share in the coming slides. So how did this process play out for updating the drill vials? Well, when the complaint was received, it's actually relevant to two different functions at Eagle who were necessary to investigate that. The first was pharmacovigilance. So again, this was a near miss, so the medication was not administered. However, had the medication been administered and had there been an associated adverse event, that would have been within the purview of the pharmacovigilance team. It also is relevant to the quality assurance team. Again, had this medication or drill vial been administered and there was no efficacy observed because it was training material, then that would have been lack of efficacy, which is a product quality complaint. So both functions needed to investigate the complaint. The two options would have been to discontinue educational support for the malignant hyperthermia space, or to update the drill vials and the educational materials appropriately. We obtained approval from leadership to update the materials appropriately. We convened a working group, and that working group, the members were listed on the previous slide. Multiple functions across Eagle were involved in both identifying the changes to be made as well as approving them once they were made. We also turned to outside experts ISMP was instrumental and invaluable in providing suggestions for updating the drill vials to further mitigate risk. And there were several external consultants that Eagle works with as well. There are 4 different types of print materials which needed to be revised and updated. One was the carton in which the drill vials are stored. Next is the labeling for the drill vial itself. The package insert that's included in the drill vial is the 3rd one. And lastly, we needed to modify the over seal tape. Once those revisions were identified, SOPs needed to be put in place to accomplish this. There are actually 2 sets of SOPs that are required for this as well. How is this going to be handled internally at Eagle? And then likewise, the product is shipped and disseminated through a distribution center that is run by a third-party logistics partner to Eagle. So we needed to understand how the process would be modified there and certainly work within their SOPs as well. Once that was all accomplished, the distribution center needed to update all of the drill vials. That was done. We at Eagle needed to confirm that all of the changes were done appropriately, and then we moved into the program maintenance phase, which is where we are now. So all of these processes were performed under good manufacturing practices. A normal timeline for a relabeling project such as this is between 6 and 8 months. This project, I'm happy to report, was accomplished in 4 months. These drill vials are quite popular and they're used as educational resources and tools quite frequently. So we recognize the importance of accomplishing this rapidly so as not to limit the supply. And now we are well into distribution of the updated or modified drill vials. So this is what the updated drill vial looks like. You'll see that the auxiliary labeling now has a different color background from the live product. And again, the auxiliary labeling is now above the product name. So if someone is scanning down the carton, they'll encounter the auxiliary labeling before the drug name. A new yellow wafer seal was added to the top of the carton. So again, you'll have to open that wafer seal and see the word demo on it. The auxiliary labeling was changed on the top of the carton. And with these improvements, we hope that we've mitigated the risk of any subsequent near miss or medication errors. So in conclusion, I'm delighted that Eagle has maintained its commitment to supporting education and training in the malignant hyperthermia space. It really does take a village to both implement a project like this, as well as identify opportunities for improvement. And we hope we've mitigated the risk of any potential medication errors. So I know, the other slide didn't. I know we're saving questions and comments to the end, but I would just like to acknowledge both ISMP, their counsel throughout this process has been invaluable. And I'd like to thank my internal colleagues at Eagle. Again, it was a cross-functional team who made this possible.
So I'd like to introduce our last speaker, Dr. Erin Fox. She's Associate Chief Pharmacy Officer at the University of Utah Health. She's probably the world's leading expert on drug shortages. Erin?
Thanks, Tricia. If I click this. There we go. I am really excited to give you all a snapshot of what is happening with drug shortages, particularly because we know that these do contribute to medication errors. So just a quick note, I've been collecting drug shortage data. Thanks, very kind introduction by Tricia, but my team and I have been collecting drug shortage data since 2001. And so we publish the information on a public website through the American Society of Health System Pharmacists. Anyone can go to that website. What we do is we get voluntary reports. We investigate those reports. We would never post anything online that someone just sent us an email about. We always confirm that directly with the suppliers, directly with the manufacturers to see, is there a problem? Is there not a problem? Sometimes there's not a problem. We do share the information with the FDA and their drug shortage team, some of my personal heroes there. And when possible, we also provide information about alternatives and safety information to really, our goal is to help a clinician try to manage through these shortages and really mitigate the impact of shortages on patient care. I think it's important to think about, what do we mean by when we say a shortage? There are a number of different definitions. The one that I use is very clinician focused, and it really means when you have to change the way that you prepare or dispense a product, or when you have to use an alternative. And you can think about how critical that is. We've just heard from, an entire morning's worth of presenters about, how critical a specific concentration or a color or a size might be. And with shortages, we are very limited in those products that we can access. Just a quick picture of national trends. There are a large number of other trends available on this public website. If you ever need these for a talk that you're doing or an update, I update these quarterly. Unfortunately, for about the past 2 years, we have been managing over 300 active and ongoing shortages. And that's a lot. We actually reached a peak of 323 active and ongoing shortages. We do track more shortages than FDA. So if you're ever comparing and contrasting those two sites, you'll see that our list is a little bit longer. And again, that's because we are more focused on specific formulations, a pre-filled syringe versus a vial. That can make a big difference for clinicians and for health systems. When I was preparing this talk, I thought it would be interesting to take a look back at the shortages that our own health system has faced. So I looked at the 45 different products that are available on our U of U Health anesthesia trays, and basically every single product in that tray between the period of 2001 to 2024 had been short at a one time or another. The only product was Gammadex. Right. And, once that goes generic, we'll probably also have shortages of that. But the average duration of these shortages is pretty long. We're looking at over 600 days. So when people talk about, well, we should have a stockpile, we should have, a huge amount on hand, 600 days is a long time. I won't kind of belabor exactly which products have been short for the longest, but you can see that table, and certainly happy to share these slides with everyone and make them all available. I think what's important to think about, when many people hear about a shortage, they think we're out. We have nothing, we have no product. And that is almost never the case. Usually what happens is you can't get the right strength or the right packaging or a different size. And it's from a different manufacturer. All of those things we know can contribute to medication errors, especially if it's a different colored cap, if the vial feels a little bit different, if it just looks different, if it's one of the code cart medications that we rely on that aren't available in that very specific packaging, and your pharmacy has to make a kit in a baggie. Imagine pulling out your code cart trays, which I'm sure many of you have, and it's just full of little baggies with little vials and syringes and kits. It's very, very frustrating. And so that's why we track these shortages and really advocate for their resolution. Quick introduction on why this is happening. Most of these shortages are generic, especially the ones in anesthesia products. I will say that, and again, this is, I could probably go for 2 hours on this topic, but I won't, I promise, Tricia. The market doesn't recognize or reward quality. And when I say quality, it's not just, is the product, exactly what it's meant to be without any contaminants or particles in it. When I say quality, I also mean, can you get that product for your patient? Is it available in a reliable supply? And there are big hurdles to regulatory entry. Even if a company wants to bring a product to market, it's going to be several years, and that's usually not enough time to make up the difference. FDA's aggregate data tells us that most of the drug shortages are due to some quality problems. The good news is that there's a lot of interest. Over the past year, there have been multiple congressional hearings, and we have the right committees involved. Now, one of those committees, Homeland Security and Government Affairs, they've actually been interested in shortages since 2018, and they've just released their second report. They're actually taking a national security approach to looking at the shortage problem, which is really interesting. And I did have the opportunity to testify for that Senate committee last year. But we also have some of the other very important healthcare related committees interested. We have Senate Finance, we have Energy and Commerce. All of these folks are interested. I know certainly nothing will happen in an election year, but there's tremendous bipartisan interest on this topic. And so I think hopefully after the election, we'll be able to keep carrying forward the momentum on advocacy. One website that I do want to call attention, if you are just looking for a quick primer, quick understanding of what policy solutions make the most sense, I call attention to my friend and colleagues work for the Brookings Institute. Marta Wasinska has been providing some really nice, very short summaries that make a lot of sense. One is we need more information about quality ratings, quality of products, that includes reliability. We also need to change health systems' incentives to actually purchase based on those quality ratings. And then for those very, very vulnerable products, maybe those that are only made in one factory, rely on one piece of raw material, we may need a small domestic stockpile. So I want to call attention to a couple of things. One is reliability. So we do need more information about reliability available. This can help the government move forward on really targeting which products are the most vulnerable. There was some legislation proposed, hopefully that will get proposed again. It's called the MAPS Act, and that really would help the US government and FDA understand which products are the most vulnerable, including those precursor ingredients that are used even before the API. Purchasers. We need to do a better job of picking the products that are going to be the most reliable. We don't have a lot of information there right now. Suppliers need to invest in having a quality and reliable product available. And then payers really do need to reward the use of those high quality products. So we really need to change the incentives. The problem is all of this costs money, and who pays? And I will argue that we are already paying the price for drug shortages. These are very costly. Your hospitals are doing a tremendous amount of work managing these shortages. They could probably mix more tranexamic acid in mini bags and make more prefilled syringes if they weren't trying to get every other drug on the anesthesia cart. But most hospitals are very incentivized on price. And honestly, that's how CMS reimburses hospitals. So we have a tough road there. So again, that policy proposal talks about ways to change those incentives. And then transparency. Again, we need to figure out a little bit more. We can't just say, make everything available on the label and make that transparent and expect that to change things. But it will help different areas of the health system and the entire market figure out what is most important. I think the most challenging thing here is that most of that information is business confidential. Which factory is that Fresenius copy product made in? Angie might tell me over a drink tonight, but she would probably have to swear me to secrecy. It's business confidential, usually which factory is making a product, where it's made, the source of the API, all of that is not readily available. So I just want to end with a few things to think about. All of these have to change if we are going to make real progress in solving the drug shortage problem. So first, the FDA tells us that all generic products are equal. That's part of the FDA rating system. That's part of how generics work. Unfortunately, the only differentiating factor there is price. And when we have a race to the bottom, it really can incentivize companies cutting corners and not having a reliable supply. We also don't really, I will just end there because I know we're short on time. And just again, talking about the transparency, that we do need a little bit more information to target the products that are most vulnerable and focus our efforts there. Thank you all very much.
Okay, we can take questions at this time. We've got about 10 minutes.
Matt Weinger, Vanderbilt. That all of your talks are wonderful and fascinating, but I guess I knew the least about the manufacturing. Can you say a little something about, imagine there were stars, up to 5 stars on every vial. How and who would determine, how many stars each vial got?
I mean, that's a great question. I was part of the National Academy of Science committee that did kind of recommend a star rating system like hospitals have. FDA actually has an internal rating system, the way that they decide which factories to inspect. I'm sure they would rather not make that public. But I think it would be very difficult, but it could be done. And I think part of that is not just that the product has a high quality as far as, does it contain what it's supposed to contain, but what additional quality measures does the manufacturer have as far as their overall quality metric system. And FDA has an entire program around that. And I don't, no time to talk through that. But do they have a backup supply? Do they have a business continuity plan? What is their plan to continue making a product?
Steve?
Thank you for a great discussion. Steve Greenberg from Chicago. Just a question on the shortages. Working in an intensive care unit and in the operating room, I always feel like we're the last ones to know about a drug shortage and the first ones to figure out what we're going to do. I wonder, we have these terror alerts, United States terror alerts, orange, red, yellow. Why don't we go back to the basics and get colors and communicate that back into the system to figure out where we are when there really is a serious problem? We had a number of shortages, as everybody remembers, during COVID, particularly with the narcotics that we were supposed to administer. And for those of you who know about anything in the ICU, we used a lot of those for young COVID ventilated patients. So I guess my question is, why don't we make it simple? And why isn't there better communication from the largest organizations down to the healthcare professionals?
There's a little bit, and the immediate response is hoarding, right? A lot of these products are very low cost. And we saw that actually with the cancer chemotherapy drug shortages that happened. When we looked back to see how much product was actually sold, it was actually more than the previous year. And yet some health systems could not access enough product and were actually rationing care. But great, we do need something like that.
So that we can be a little bit more proactive. So when it turns yellow, people start thinking about it rather than we're way in the red.
And I will tell you that in many cases, pharmacies find out about a shortage when their order doesn't arrive. So ordering drugs is not like ordering things on Amazon. You place your order, you hope that your wholesaler will send you that amount, but sometimes you get a tenth of that or zero. So often it's a very bad surprise.
Right. And if I could just add, one of the challenges is at the glycopyrrolate example where there's 18 manufacturers. So if one manufacturer has a manufacturing delay, then it's trying to understand, is this going to cause a shortage or will someone else be able to fill in that gap? So it is a very complex situation, and we're open to any feedback on how to communicate that better. Because it is a challenge.
Nate?
Hi, Nat Sims, Mass General. I have a two-part question for Angie. And it relates to Rita Jew's example of Milrinone, where the concentration didn't match the drug in the bag and it was giving 20 times too much. So 16 years ago, I attended a conference in Boston sponsored by J&J, and where most of the speakers were from the GS1 organization, saying that imminently we would have the GS1 standard for 2D data matrix barcodes on every drug vial and potentially every syringe, and that imminently we would have an RFID so that there could be auto recognition either by a camera in an infusion pump or near field communication in a pump to ensure that we never had a mismatch between the drug name, the drug concentration, and what the pump is thinking it's trying to do. I'm wondering what happened in those 16 years.
Thank you for that question. Well, we are getting started. I will say we're at the beginning phase of this, and I'll mention RFID is following the GS1, which is the global standard for identification. It's what is currently being used for the 1D linear barcode. We also use it for the 2D data matrix barcode, which right now the mandatory requirement for DSCSA is that there is a 2D data matrix on every unit of purchase. So the carton has to have that 2D data matrix. Fresenius Kabi is committed to putting it on all of our unit of use, our individual products. And I think you're going to see other companies start to follow suit, but it's not a mandate yet. But we have already started that process. RFID also uses GS1 standards. There are GS1 standards out there. And what that does is it allows for interoperability. And what we would like to see is more readers at the point of care. Right now, RFID is being used for inventory management. The readers are primarily in the pharmacy. But if we could grow that use case, think of the potential for auto-identification of medications at the point of care. It is a passive technology that is supportive of your anesthesia workflow. And we could use that to help with medication use safety.
Follow-up, I wonder if we should have a poll later today or tomorrow where we ask the audience, should infusion pumps be able to implement auto ID or any syringe or bag container? And, you know, is that something
Yes.
we should fight for and try to move forward? To point out that everybody knows that FK makes.
Yes, we make infusion pumps, and we have 20 RFID smart labeled anesthesia products right now. So it is coming. It's building. Right.
Thank you, Nate. Gentlemen?
All of our containers have caps on them. Is it sterile underneath the cap? Is it sterile underneath the drug?
No,
cap?
no.
Thank you.
No, it is a dust cover. It is not sterile. Aseptic technique is still required.
Sir, at the other microphone.
Hi, Chase Sims, Mayo Clinic, Rochester. Just a quick question, I think, for Angie, who you mentioned the seal on the drug vials. I imagine just a thin piece of aluminum. Has there been any appetite for, you mentioned it could be colored, but has there been appetite for coloring it across medication class?
Well, I do want to point out we have two individuals from West Pharmaceuticals here, and they are the makers of the seals, caps, and everything. If you could just raise your hand if you want to talk to them later. John and Erica. There is opportunity to use color for the seals. Diprovan is an example that I think everybody here is familiar with. Diprovan has a blue seal. Most vial products are using just the metal, the aluminum right now, but there is an opportunity to do color. It does add cost. There's actually another option for manufacturers. There's actually some vials, and I believe lidocaine, bupivacaine, there's one manufacturer that makes the vial without the cap, and it's a pull ring mechanism. So it's just that metal aluminum top is there in the pull ring. That is actually a very old technology, but it is the cheapest. So that's why it's still out there. So caps cost a little bit more, but there's more flexibility in selecting color. And I've been just happy to hear from my regulatory team and our manufacturing folks that changing a cap color is minimal. Nothing is easy, but it's minimal effort for a manufacturer to make that change.
Thank you, Angie. Jeff?
Yeah, if 98% of the drugs have some drug shortage, and it's really not a fixable system, should there be an emergency manual for every drug as to what you're going to do when the shortage happens?
There could be, although sometimes it depends on what the alternative is available, right? And if that's short too, do you need a fourth or fifth choice? Yeah.
Bev?
A sort of a question and then sort of an idea. First, to Rick Botney, you said that all the ASTM labeling standards were withdrawn in 2022. What happened? Why then?
That was a combination of apparent lack of industry support for them and ASTM. This is a personal communication to me from the folks at ASTM, is that there was nobody within the organization or on the committee to champion their revision.
So they're believed to be outdated and no one was.
They are periodically revised, and when they came up for revision, there was nobody to do that.
Good, fair
champion
enough.
them.
When I didn't know how nefarious the understory was. There is, I think I understood that we're later maybe even going to have a poll on supporting barcodes and other automatic reading of labels. I think, you can kind of guess most people are going to be in favor of that. But the issue is dealing with why not yet? That 17-year, why not yet? And there are only sort of two ways to get it done. One is to make the financial case, which in our current healthcare environment is not the right kind of financial people actually want to act on, or the people are making decisions. But the other approach is regulatory. And this is, I wonder that we should also, that this organization and all the related organizations, for example, petition the Joint Commission to make this a standard, to talk to other regulatory organizations that could do a little bit of arm twisting for this kind of safety. Thank you.
Jeff Feldman, Philadelphia. We've heard repeatedly that the color of the tap is the source of medication errors because the caps really can't be uniquely colored the way we would like. What is the value of coloring the cap that warrants the risk of a medication error? And should we have clear or white caps so on all medication vials so that we are more compelled to read or barcode the drug before we give it?
I don't think that was a question, but Jeff, that sounds an awful lot like all of our user applied labels should all be white with black printing and do away with color coding altogether, which is a topic of great debate. And I know some people in this room fall on the side of white labels with black printing. Personally, I think that there is a fair bit of value to color coding. And back in 2001, that's what Mary and Webster suggested in their article to prevent the interclass drug errors.
And if all labels are white with black, your system one will have a heyday because you can look at it, and if it doesn't fit the mental model of what you're doing, you may not read it correctly. You are looking at it, may not read it. Bringing in colors uses a different sense, if you will. And then, of course, the barcode administration brings in another sense, the auditory. All of these things help reduce system one's substitution, if you will.
Chris?
What that's really telling us is that redundancy is a good thing, redundant channels. And as I said in my talk, there's at least one paper that showed that even with correct labeling, that they were misread. So forcing reading of the label is not going to eliminate medication errors based on the labeling.
I don't care how big your whip is.
Chris?
Right. I wanted to take a couple of minutes, not minutes, but a couple of comments. First to say, I want to congratulate Angie for presenting the quality data, which actually doesn't show Fresenius in great light. I mean, when's the last time we stood up and did that, in an M&M? But that's great. I'd hope to see more of that from industry. The second is this conversation around manufacturers, distributors, pharmacies, the pharmacies and the hospitals and the end users is very similar to an MIT game, which is called the beer game. And maybe all of us should play it because we got the right players here. But it really forces us to think about shortages at the manufacturing center, the distributor, and it's driven by consumers wanting more, or the shopkeepers in this case, because it's a beer game, the shopkeepers wanting to stock more, because we discussed that as well. And finally, I wanted to also say it's fascinating to watch us try to make us smarter through these things when in fact our brains are reliably and easily distracted. So should we be moving away from depending on humans entirely for this, which I know that some of our colleagues have spoken about, but the standard right here is a human standard, which is really quite weak on the scale of effective change.
Lynn, one more question.
Well, I am the representative of 84 folks online and Zoom attending this conference. So thank you all for your questions and for using the microphone. They really appreciate that very much. So right now I have 5 questions, so I'll select one. How's that? Angie, do you or anyone have an idea? And congratulations for joining the APSF board as well, if I may be the one to say that out loud. Pre-filled syringes in the US, what percentage is currently, do you know the percentage?
I'll have to get back to you on the percentage. It is not easy to calculate because we use IQVIA data to help calculate market shares for manufactured drugs, but the majority of the pre-filled syringes today are made by 503B compounding companies. So, and that is not picked up in the IQVIA data, but it is, can I answer? It's not enough. We need to continue to bring these combination products to the market. It's a combination approval process. Our FDA file, it's drug plus device. And it is the best way to have a ready to administer product with the full label and the barcode. And we're starting to bring those pre-filled syringes to market with an RFID label as well.
And Lynn, when the poll, in the pre-conference poll, we asked what risk strategy initiative do you think has the greatest impact? And it was pre-filled syringes. And I'm sorry, I think we better conclude.
We can maybe, yeah, we're going to take a 5-minute break. We have a big treat ahead, which is the pioneer session. So 5 minutes. And then G, if you want to come up to the front and maybe ask the panelists while we do some moving on the stage, that would be great. Thank you all. And I want to thank the moderator, Tricia, Meyer, and all of our esteemed panelists for an excellent session. Thank you.